Yeah, thank you very much for that introduction. I'd like to thank the organizers for inviting me to this meeting. Actually, when I decided to come, the motivation was to learn rather than to give any talks. Before I go through what I'm going to say, I would like to sincerely thank the American people for PEPFAR. You know, I worked with HIV before PEPFAR, and I was running a clinic, you know, with my own money and trying to do the best I can. And, you know, it was really pathetic. You know, you could see the patients this week, and the following week you don't see them. Today, when we run our clinics, you know, they are just happy people. And well, I know people may not know what PEPFAR does, but I personally feel I'm very grateful to PEPFAR for doing that to our people. They are no longer dying like cockroaches, you know. They live and take care of their families. So let me go to the cascade of HIV care in Uganda. I know this is something that many people know about, but I personally think it's so critical if we are to have the full impact of ART. Is this? So I'm going to have like a brief background, then tell you a little bit about the national picture of the cascade, and I'll tell you also, you know, the hospital, sort of the ward where I work, the infectious disease ward, which has, you know, lots of HIV patients, and also comment on one of the implementing partners, PEPFAR implementing partners, the MJAP, and also make some comments about one of the studies that we have between Makerere and UCSF called the START-ART, which aims, you know, to promote starting of ART, you know, soon after eligibility. This is well known to this audience. Successful HIV requires early identification, immediate linkage, and long-term retention on potent ART. There have been papers that have defined the stages of pre-ART care. There's a stage from testing to staging, you know, which, you know, in one of the reviews, you know, 2/3 of people are were assessed within 3 months, meaning that 1/3 was not. There's also a stage from enrollment in pre-ART care to ART eligibility. So some patients are not eligible immediately, you know, following them up from the time of linkage to ART eligibility. And then stage 3 is the stage from ART eligibility to ART initiation. This is a slide borrowed from somewhere showing the cascade. And the reason for showing this slide is that at every stage there's leakage. And you know, we lose people. You know, we retain just a few people, you know, from here to here, from diagnosis to staging, from staging to ART eligibility, and all over. So people leak. So we end up not getting the full impact of ART. So let me tell you a little bit about the national picture of. Hope this will. So, does it come out? Well, I think I'll just talk about it. Well, you know, I got, you know, this information from our Ministry of Health, and, you know, we did a survey in 2008 looking at our cascade and looking at several hospitals around Uganda. And, you know, what we found was that 54% of patients in pre-ART, you know, got lost. You know, people who were brought into treatment, you know, we were losing like half of them in 2008. And most of those, 1/3 of those people who get lost are eligible for ART. And most of the people that get lost within the first, you know, within the first 3 visits. You can see here, the people who get lost early. In fact, we think that we should get people on treatment immediately. We link them to care, because when we don't, we just lose so many of them. This is a slide also showing the Cascade nationally. Now, this one is more recent, in 2002, and looking at early infant diagnosis. And we looked at 306 facilities, 1,361 mothers. And as you can see here, these are the total number of people, total number of clients, and then the total results received by facility. Now, as you can see here, we begin to lose people, and 40% of loss in clients is because the mothers don't come back for the tests of their children. This is a very, very critical part of EID. If we don't improve this, if we don't improve, if we don't understand why mothers don't come back for the results, we are unlikely, to improve this impact of ART in kids. This is a ward where I work at Mulago Hospital, and I wanted to give you some flavor of this person is probably known to some people. Yeah. So this is the ward where I work. It's very crowded, and most of these patients come in very late. They come in with crypto, TB, and we take a lot of time trying to treat them, and we use a lot of resources to treat them. We would like to reach a stage when HIV is an outpatient disease, just like it is in the Western world. But we still have lots of people coming in late. So late-stage diagnosis is very common at our hospital. So we looked at this some time ago, testing 1,966 patients, and we found that 47%, had CD4 of less than 250. In fact, among medical inpatients, 2/3 of patients had CD4 less than 250. So late-stage diagnosis is still very common in our hospital setting, and that increases the risk of death, and of course, increase in utilization of medical care resources. One of my students, I told him, we worked out with her a study to look at how many patients on our ward do we start on treatment within 2 weeks. And actually what we found is that 75% of our patients on my, I should be ashamed of this, 75% of patients on my ward don't start ART within the 2 weeks time frame. And the reasons for not starting ART really is that we take time preparing patients, counseling visits, trying to make sure they understand ART, and we don't start them, and certainly that increases the risk of death. But also, when we do referrals, people do not come back on the dates that we give. So anyway, there are opportunities, to keep understanding, these components of the cascade so that we improve outcome of our patients. Now, this is some experiences from the MJAP program, which is the Makerere University Joint AIDS program, which I'm associated with. Recently, we reviewed registers of patients that we test. We do a very, we have a very big testing program, provider-initiated HIV testing and counseling. So we reviewed 19,000 patients who had gone through PITC, and out of those, these were infected. And then we did a random sample of 867, and this doesn't come out well. Well, out of that random sample of patients that we had tested for HIV, 247, we didn't know what had happened to them. And among these ones, these were still alive. So most of them, we could trace them. Then we among the 500 that we got hold of, 91% had linked to care, 9% not linked, and the medium linkage was 3 months. Anyway, our conclusion was that the majority of patients that we managed to track down were successfully linked to care, although, of course, there's still that proportion that we didn't get hold of. And we also found that being young age and being single were predictors of not being in care. Then we also did a study together with my colleagues at UCSF, looking at the lost follow-up among people who have high CD4 counts, more than 350, and lost follow-up was defined as being absent from the clinic for 9 months. And what we found, again, this is the MJAP program, we found actually that retention wasn't as bad as we thought. For example, 70% were retained in our clinics, but if you look at retention overall, because some people moved to other clinics, overall it was close to 90% were retained in care. So in other words, if you really look very hard, people get linked somewhere. So these were our conclusions, that 90% of people are retained in care over a period of 2.5 years, and 50% of people whom we think are lost are actually retained in care somewhere else. And socioeconomic factors are the strongest determinants of disengagement. I'm about to finish. This is a study that we have started with Elvin and Diane and others. We call it the START study, trying to abbreviate the time between ART eligibility and the starting of ART treatment. We call it the START ART study. This is based on trials that are known to everyone in the audience, the trials that beginning ART within 2 weeks improves mortality and other data. So what we are doing in this study is that, we are trying to have people, whenever they come into clinic and they're eligible for treatment and they're enrolled, we do a point of care test so that they can be staged right away, determine eligibility, and start them on treatment. So this is in comparison to the standard of care where, we take this visit and that visit and that visit, and then people begin ART on visit 4. And by this time, so many people are lost or die. So I think this is a very important study for us to improve what's going on, especially, the bad picture that I painted at the beginning of my talk. This is really trying to illustrate it in another way, that you try to move away from this kind of approach to where you start people in the first visit or the second one. I think I should. So in conclusion, anyway, we've made remarkable access to ART over the past 10 years. In Uganda, I've been there seeing it happen. But we still have major gaps in the HIV care cascade, and we've started to do some implementation science to address this, but it's certainly a big problem. But we hope that with this catalyzing of implementation science at UCSF and beyond, the spirit of this meeting, that with that motivation, we shall, improve ART delivery and improve the ART impact in our countries. Thanks again for inviting me to this meeting, and thanks all of you.